Thank you very much, and it really is my pleasure to be here. I'm just loading up the slides here as we're running through them, if they can be put onto here. And the context of this is that certainly in many areas, anti-VEGF era has halved the amount of blindness within the community, particularly from neovascular AMD. And I'm just loading these up if I can, or if you can load them up for me. So it's half the amount, but the fundamental question is, are all anti-VEGF agents the same, particularly within the current environment? And thank you for bringing up these slides. That's very helpful indeed. So a few disclaimers, and please note my financial disclosures before I start. So we're going to explore the molecular properties of anti-VEGF agents initially, and I think this might be familiar to many people. There are really 5 characteristics that combine well to how well an agent suppresses anti-VEGF. There's potency, the strength, there's the affinity, how well it binds to the molecule, there's the targets, and those targets may be different, there's the dose, and something called ocular clearance, how well it's cleared out of the eye. So we're going to look at those first 3 initially and come to the rest later. So we're going to talk about aflibercept initially, and aflibercept has a very high potency, has a very high binding to a low dissociation constant, and actually binds a whole range of targets, not just VEGF, but galactin-2 and placental growth factors, for example. So it makes it well positioned to block anti-VEGF. So let's just talk about VEGF pathway. The 2 principal pathways are the VEGF-A pathway through VEGF receptor 2. There's placental growth factor, which blocks VEGF receptor 1. And both of those mediate to cause inflammation, neovascularization, and retinal vascular leakage, which are the main reasons why we cause vision loss in these retinovascular diseases. So not all anti-VEGF agents work solely through these pathways or completely through these pathways, and may look at different pathways. But aflibercept binds VEGF-A and in fact traps placental growth factor as well. So stops that cross-talking between those VEGF receptors and hence neovascularization. And there's evidence for all this, that actually placental growth factor is important in diabetic retinopathy leakage and perhaps also in preventing neovascularization as well. So let's just explore the durability of anti-VEGF agents. So why is this important? Well, the durability, the how long it lasts, is mooted to be the biggest or one of the biggest unmet needs that most physicians, ophthalmologists feel is lacking with agents at the moment. Our ability to extend longer intervals to reduce the burden on patients and healthcare systems alike. So let's just talk a little bit about the traditional treat and extend approach, which allows an interval extension up to every 12 weeks or so. And we can see these really good studies here. Principal studies looking at ranibizumab, bevacizumab, and aflibercept, and they all actually have good visual acuity outcomes through year 1, year 2 with a positive gain. But we can see from the middle line there that's actually quite burdensome in terms of the amount of treatments, and in fact about 20 to 30, perhaps even up to 40% only get out to 12 weekly dosing here. But there are level 1 evidence, which is through indirect comparison. We have to be a little bit cautious with indirect comparison, looking at key studies to try and understand which medication, which treatment regimen are more favorable. And there's a comparable visual gain with ranibizumab compared with aflibercept, but we see that there's typically in year 2, less intravitreal treatments required, and that addresses this unmet need of reduced amount of treatments that we're searching for in our treatments. But actually it's not just real world, it's not just randomized clinical trials, but it's also real world evidence that supports this. So on the left hand side here you can see 2 key trials, the Altair and ARIES, looking at and studying aflibercept 2 milligrams. And on the right hand side, and particularly the far right hand side, real world evidence from Moorfields, where we see that there's still good visual acuity gains through year 4. But indeed, there are still a number of injections required, perhaps over in 3 or 4 in the final 3 or 4 years. So in diabetic macular edema, there is a similar picture here. So good visual acuity gains with aflibercept 2 milligrams, And in these studies, which are particularly from East Asia, we see good visual acuity gains, but again with a significant amount of retreatments required through year 1 and year 2. So let's get back to really where the new generation of anti-VEGFs are supporting this concept now. So there are through either new molecular targets or in particular molar dose. So aflibercept 8 milligrams is 4 times more than 2 milligrams, so a higher molar dose. But actually surprisingly through study, the formulation seems to clear out of the eye at about a rate of third less quickly than the 2 milligrams. So this is sort of additional benefit that many people were surprised about. And what does that mean? It means that when it was studied in good quality randomized controlled trials, and this one is the PULSAR trial studying neovascular AMD, that around about 6 out of 10 individuals were achieving 16-week intervals or more when treated with 8 milligrams of aflibercept. And that figures about 4 out of 10 of greater than 20 weeks, or 20 weeks or greater than 20 weeks, through to studies of 156 weeks into the clinical trials. And very similar study with a photon study, which was an equivalent or similar study studying patients with diabetic macular edema. So about 7 out of 10 and 5 out of 10 respectively, participants treated with 8 milligrams were being assigned to 16 weeks or more, 20 weeks and more respectively at the end of the study. And that's actually quite a shift in what we've seen from the first generation medications. So it therefore brings this concept of sustained disease control. And what do we mean by that? We mean really the triad of lasting visual gains, good, robust fluid control with extended treatment intervals are wrapped around a safety profile. Now what's very relevant, and particularly in this part of the world, is the treatment of polypoidal choroidal vasculopathy. And let's just have a look at monotherapy. So monotherapy with aflibercept 2 milligrams has been studied in PCV in relatively small numbers in the VIEW studies, as we see on the left-hand side, but with good visual acuity gains. And then specifically compared with monotherapy plus rescue therapy with PDT in the PLANET study. And once again, we see good visual acuities. But what was interesting of this study is actually monotherapy worked just as well, and numerically slightly better than the combination with photodynamic therapy. And really, this meant that more than 80% of patients didn't require the photodynamic therapy and led to APVRS releasing the comment that this level 1 evidence supports its efficacy use as the first-line treatment in polypoidal choroidal vasculopathy. And actually that's quite different to the EVEREST-2 study where ranibizumab was compared with ranibizumab initially with PDT versus ranibizumab alone. And in that circumstance, ranibizumab alone required more treatments and didn't have the same visual acuity outcomes. Not quite as good there. So perhaps if ranibizumab is used and we're wanting the best evidence for best outcomes, then it needs to be combined with photodynamic therapy. So it has been studied in different newer generation medications, and we'll just talk about that. So with infliximab, that also targets anti-VEGF, a relatively small amount of patients were confirmed to be studied in Tenaya and Lucerne study, and hence the development of the SALWEEN study, which looked very specifically of a PCV population in Asia. And I think it'd be fair to say that there were an increase, and a good increase, in visual acuity, but what hasn't been studied is whether there was benefit in having photodynamic therapy in addition to this particular medication. And in fact, that's the same situation when we look at brolucizumab. There still is that unanswered question of whether there could be an enhanced benefit or any benefit at all of adding in photodynamic therapy. So real-world patients with polypoidal choroidal vasculopathy do achieve comparable visual acuity gains to those with aflibercept 2 milligrams, as we can see here, around plus 6 to 7 letters out to year 1 and year 2. And in fact, the aflibercept 2 milligram monotherapy achieves control of polypoidal lesions, so closure of the lesions, in real-world cases in around about 40 to 50, even up to 75% of cases. And it's the closure which are really quite important. So what about aflibercept 8 milligrams at 4 times higher molar dose with reduced clearance? Good visual acuity gains, numerically slightly better than 2 milligrams than the non-PCV cases. Good sustained retinal fluid control, but we see here that with less injections, 7.7 through year 2, and that gives longer extensions in the long term for our patients. So just quickly in the last few moments, exploring the safety profile of anti-VEGF agents. Of course, the more we challenge the immune system with proteins, the more we might expect inflammation. I think it'd be reasonable to say that from real-world evidence, brolucizumab has a higher intraocular inflammation rate that's been reported in many jurisdictions, and a much lower with faricimab, and numerically slightly lower again with aflibercept 2 milligrams and 8 milligrams. With over 84 million doses sold since launch, it really gives us confidence that aflibercept is a safe molecule to use in clinical practice. So 2 milligrams and 8 milligrams have similar low rates of inflammation in the both PULSAR and the PHOTON study. So just to summarize, so aflibercept 8 milligrams has a very favorable binding affinity and potency. It's 4 times a higher molar dose, and therefore explains this longer durability profile we're beginning to see. It's also effective in polypoidal choroidal vasculopathy. And I'd like to thank you very much for your attention. Thank you very much.
Thank you, Dr. GALE. Please join us on the dais. Are there any questions for Dr. GALE? Otherwise, maybe we can have a discussion at the end of the lectures.
Was any independent
Yeah.
study conducted for 2 milligram and 8 milligram for inflammation, ocular inflammation? Any independent study between these two doses?
Yeah, there's been no separate study specifically looking at safety profile, but safety profiles are a really important outcome in the landmark clinical trials. So the PHOTON study was a phase 2/3 looking at both efficacy and safety, and a very important outcome in neovascular AMD. And the balance of intraocular inflammation is very similar between the anti-VEGF, between around about 1 to 2%. And that's if you look really hard for it indeed. The inflammation that we're most concerned about is occlusive retinal vasculitis, and there were no cases reports of occlusive retinal vasculitis in either of the groups in both of those two studies.